Hi all, welcome to the module on upper gastrointestinal and hepatocellular carcinomas. I am Dr. Courtney Cavalieri, clinical oncology pharmacist at the Huntsman Cancer Institute at the University of Utah in Salt Lake City, Utah. This presentation is part of the ASHP ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. I have no disclosures. The learning objectives are provided for you here in the presentation as well as the handout. And we will get started today with gastric and esophageal cancers. We will start off with our first audience response question. KW was recently diagnosed with localized gastric cancer. It was decided she will undergo perioperative chemotherapy with surgery. Which of the following perioperative regimens is most appropriate for KW's localized gastric cancer? A. EOX, which is epirubicin, oxaliplatin, and capecitabine. B. 5-FU plus oxaliplatin plus radiation. Or C. FLOT, which is 5-FU, leucovorin, oxaliplatin, and docetaxel. Or D. carboplatin, paclitaxel, and radiation. The correct answer for this question is C, FLOT, 5-FU, leucovorin, oxaliplatin, and docetaxel. This is based on the FLOT-AIO trial, which showed significant improvement in overall survival with perioperative FLOT over the ECF-ECX regimen, which I'll go into in a few slides. Answer A is not appropriate due to the removal of ECF and its modifications, which includes EOX, from the perioperative regimen recommendations in the NCCN guidelines. Answers B and D are not appropriate perioperative regimens at this time due to the inclusion of radiation. These regimens would be more appropriate for preoperative or definitive treatment of localized or locally advanced esophageal cancer, respectively. When we look at the treatment modalities for gastric cancer and esophageal cancer, we're going to see the same three treatment modalities we see for most solid tumors, and these are surgery, radiation, and systemic therapy. The primary goal for localized disease is cure with surgery, otherwise the goal shifts to palliative. For gastric cancer, patients will undergo gastrectomies if they undergo surgery, and for esophageal cancer, this will be an esophagectomy. Radiation can be used in the neoadjuvant and adjuvant setting combined with chemotherapy, or it can be used in a definitive setting combined with chemotherapy for unresectable disease. Radiation on its own can also be used in the palliative setting. Systemic therapy can be used in the neoadjuvant or adjuvant setting. We know that it prolongs survival in metastatic disease as well. And the systemic therapies that we see for these disease states include the fluoropyrimidines, platinums, irinotecan, taxanes, and a few targeted therapies such as Trastuzumab, Ramucirumab, and Immunotherapy. We're going to look at localized gastric cancer treatment first. These patients are split into two categories based on their clinical presentation. Medically fit patients are those that are able to tolerate major surgery, and non-surgical candidates are those that are medically unfit for surgery or medically fit who decline surgery. For our medically fit patients, we typically want them to undergo surgical resection. And this could either be surgical resection first, followed by surveillance or chemotherapy with or without radiation. Or it can be surgical resection essentially sandwiched between chemotherapy, and this is called perioperative chemotherapy. Patients can also undergo preoperative chemoradiation followed by surgical resection. For non-surgical candidates, they are really only eligible for systemic therapy or other palliative management. Perioperative chemotherapy is really the standard of care for localized gastric cancer treatment, and this was first established based on the MAGIC trial, which looked at the ECF regimen in patients with adenocarcinoma of the stomach or the lower third of the esophagus. The authors compared 3 cycles of the ECF regimen pre and post-surgery versus surgery alone, and found that the perioperative chemotherapy significantly increased progression-free and overall survival versus surgery alone. So ECF and its modifications were the standard of care for perioperative chemotherapy for many years. However, even with the modifications, every regimen included epirubicin, which caused significant toxicities for patients. Therefore, other regimens were looked into, and we finally were given the FLOT regimen based on the FLOT-AIO trial. This trial looked at patients with adenocarcinoma of the stomach or gastroesophageal junction who had had no prior systemic therapy and randomized them to either receive FLOT or ECF or ECX perioperatively. FLOT was given as a 14-day cycle, and therefore 4 cycles were given pre and post, versus ECF and ECX is given as a 21-day cycle, and therefore 3 cycles were given pre and post surgical resection. The authors found that FLOT significantly improved median overall survival to 50 months versus the 35 months they saw with ECF and ECX. The FLOT trial also saw significant improvement with progression-free survival for FLOT versus ECF and ECX. And the grade 3-4 adverse drug reactions were not unexpected, but were different between the 2 groups, with more nausea and vomiting, thromboembolic events, and anemia seen in the ECF-ECX group, and more neutropenia, infections, diarrhea, and neuropathy seen in the FLOT group. Based on this trial, FLOT replaced ECF and its modifications as the standard of care for perioperative chemotherapy in the NCCN guidelines. And as of the most recent update, ECF and its modifications have actually been completely removed from the guidelines for perioperative therapy. So when we look at what the NCCN guidelines actually have for recommendations for perioperative chemotherapy regimens, we see FLOT as a Category 1 preferred regimen, but 5-FU or capecitabine plus oxaliplatin, essentially FOLFOX or CAPOX, is also a preferred regimen. Cisplatin with 5-FU or capecitabine is also a Category 1 regimen. However, due to the higher toxicities seen with cisplatin versus oxaliplatin, it is not considered a preferred regimen. Now moving on to localized esophageal cancer treatment, we have to take a few more things into consideration. Esophageal cancer typically presents as one of 2 histologies. It can either be adenocarcinoma or squamous cell carcinoma, although there are mixed histologies that are diagnosed. Histology affects incidence, risk factors, and prognosis, and this is in greater detail in the handout. Again, we're dividing patients into 2 categories, whether they are medically fit or non-surgical candidates. Those who are medically fit have many options for interventions, most often some kind of resection with or without chemoradiation or even definitive chemoradiation. Patients with adenocarcinoma histology are also eligible for surgical resection followed by adjuvant chemotherapy or a perioperative chemotherapy approach similar to that of gastric cancer. Patients with localized esophageal cancer who are non-surgical candidates have much fewer options. These include endoscopic resection, definitive chemoradiation, or palliative radiation or best supportive care. Probably the most common intervention you'll see for localized esophageal cancer patients is preoperative chemoradiation prior to surgery, and this is based on the CROSS trial. The CROSS trial included cancer of the esophagus or esophagogastric junction of any histology and randomized patients to either receive preoperative chemoradiation with carboplatin and paclitaxel before surgery or surgery alone. They found that overall survival basically doubled in the preoperative chemoradiation group, and this was significant. So therefore, this became the standard of care. When we look at the official NCCN recommendations for chemoradiation regimens, you'll see there are quite a few different regimens, with a variety of them being Category 1 preferred or Category 1. You'll see the common theme, though, of taxanes and platinums and fluoropyrimidines. And so choosing one of these regimens is really going to be based on probably institutional preferences as well as patient tolerance. So that concluded the discussion on localized esophageal and gastric cancer treatments. We're going to move on to chemotherapy and systemic therapy for unresectable, locally recurrent, or metastatic gastric and esophageal cancers. You'll note that in localized disease, these are treated quite differently most of the time. However, for these locally advanced or metastatic cases, gastric and esophageal cancers are treated similarly. So moving on to our second audience response question, we have FT, who has a newly diagnosed metastatic intestinal type gastroesophageal junction cancer. He will be starting cisplatin and capecitabine. Screening for which of the following tumor markers should be performed in consideration of targeted therapy? A KRAS activating mutation, B, BRAF V600E mutation, C, HER2 new expression, or D, an ALK fusion. The correct answer here is C, HER2 new expression. We know that HER2 overexpression occurs in about 20 to 30% of patients with gastric cancer, and I'll discuss this more in a couple slides. Answer A is incorrect at this time. And unlike our lower GI cancers, in which KRAS activating mutations dictate if we can use EGFR inhibitors, EGFR inhibitors haven't shown to be effective in our upper GI cancers. Answers B and D are incorrect. Although there are targeted therapies both for BRAF mutations and ALK fusions, they are fully experimental in upper GI cancers at this time, and not indicated either through FDA approval or through NCCN recommendations. So now delving into what actually is recommended, we'll start off with our first-line chemotherapy options. There is no established standard of care for first-line chemotherapy for these upper GI cancers. However, the NCCN does support 2 cytotoxic drug regimens over 3 cytotoxic drug regimens, and that's mostly because 2 drug regimens have fewer toxicities and 3 drug regimens haven't really been shown to improve overall survival. However, 3 drug regimens can be used for those who are medically fit with a good performance status and who have access to frequent toxicity evaluations. 2 drug regimens typically are platinum-based and either have cisplatin or oxaliplatin with a fluoropyrimidine. The 3 drug regimens typically add a taxane or anthracycline to the 2 drug platinum regimen. As covered in our patient case, we also want to evaluate these patients for HER2 expression. As I mentioned, HER2 amplification occurs in about 20 to 30% of gastric cancers, and we see a little bit of difference in esophageal cancers based on histology. HER2 amplification is more common in adenocarcinomas with up to 30% of cases, versus squamous cell carcinomas only have about up to 13% of cases with overexpression. All patients with advanced gastric, esophagogastric junction, or esophageal adenocarcinoma tumors should be tested for HER2 expression. Testing and the results of these testing follow along the guidelines recommended for breast cancer, and we see the greatest treatment effect found in tumors that express HER2 with IHC2+ and FISH positive or IHC3+. Any of these patients who are found to be HER2 positive are eligible to receive therapy with Trastuzumab in the frontline setting. This recommendation to use Trastuzumab in the frontline setting is based on the TOGA trial. This is an older trial, and so I won't go into the details that much. However, this trial looked at Trastuzumab added to frontline chemo versus frontline chemo alone. And they found that the addition of Trastuzumab significantly improved response rates, progression-free survival, and overall survival without increasing toxicities significantly. Therefore, based on the TOGA trial, the NCCN does support adding Trastuzumab to first-line chemotherapy for adenocarcinoma tumors that overexpress HER2. The combination of 5-FU plus cisplatin does have a Category 1 recommendation, strictly based on the fact this was the regimen used in the TOGA trial. A very new update to our frontline systemic therapy options came about with the most recent publication of the NCCN guidelines this past December, and that is using immunotherapy with chemotherapy in the frontline setting. Both Checkmate 649 and Keynote 590 were initially presented at the ESMO Virtual Congress 2020. Checkmate 649 looked at Nivolumab plus frontline chemo in HER2-negative patients with advanced gastric, esophagogastric junction, or esophageal adenocarcinomas, and they found in their initial results that the addition of Nivo to first-line chemo improves overall survival and progression-free survival, specifically in patients with PD-L1 CPS of 5 or greater. The Keynote 590 trial looked at Pembro plus first-line chemo in patients with advanced esophageal cancers or esophagogastric junction cancers. They found that the addition of Pembro to first-line chemo improves overall survival, progression-free survival, and overall response rates. So when we look at the NCCN recommendations for first-line therapy for upper GI cancers, patients are broken into two groups, whether they are HER2 positive or HER2 negative. Those with HER2 positive adenocarcinoma are eligible for a regimen including Trastuzumab. Those who are HER2 negative are eligible for chemotherapy with or without immunotherapy. Nivolumab can be added to chemotherapy for adenocarcinomas only that have a PD-L1 CPS of 5 or greater, and Pembrolizumab can be added to chemotherapy for esophageal or esophagogastric junction cancers only with PD-L1 CPS of 10 or greater. If patients are not otherwise eligible for the first-line regimens on the previous slide, there are other regimens that are recommended in the NCCN guidelines, most often including a taxane or irinotecan. So with that discussion on frontline systemic therapies, we'll now move on to what do we do in the subsequent line setting. We'll start with GM, who has undergone 10 cycles of FOLFOX for metastatic esophageal squamous cell carcinoma with good tolerance. Unfortunately, recent scans show progression of his disease. Molecular testing reveals microsatellite stable and PD-L1 combined positive score of 2. Which of the following regimens is most appropriate for second-line treatment for GM? A. ECF, epirubicin, cisplatin, and fluorouracil. B. Pembrolizumab. C. Ramucirumab plus paclitaxel. Or D. Nivolumab. The correct answer is D, Nivolumab, and this is based on the ATTRACTION-3 trial that showed significant overall survival improvement of Nivolumab over chemotherapy in the second-line setting for metastatic esophageal squamous cell carcinoma. Answer A is incorrect because 3-drug chemotherapy regimens are not used or recommended in the subsequent line setting. Answer B is not appropriate at this time because pembrolizumab is indicated for second-line treatment in esophageal squamous cell carcinoma only if the tumor is MSI high or has a PD-L1 CPS of 10 or greater. Answer C is incorrect because ramucirumab-based regimens are only indicated for adenocarcinoma histologies. For subsequent line therapies, I will focus on the immunotherapy data for the presentation. I'll refer you to the handout for more data on the other subsequent line regimens. When we look at pembrolizumab, there are 2 keynote trials, 059 and 181, that support using pembrolizumab in the subsequent line setting. Keynote 059 looked at gastric or esophagogastric junction adenocarcinoma patients with disease progression on at least 2 prior systemic therapies with PD-L1 status of 1 or higher. So these are patients essentially in the third line setting or higher. The authors saw an objective response rate of 13.3% and a duration of response of up to 19 months. Adverse events were similar to those previously reported. Keynote 181, however, looked at esophageal cancer patients of any histology with disease progression on 1 prior systemic therapy with a PD-L1 status of 10 or higher. They didn't see an improvement of overall survival in the overall population. However, there was a clinically meaningful improvement in those with squamous cell carcinoma. As I mentioned in the audience response question, the data supporting nivolumab came from the ATTRACTION-3 trial, which compared nivolumab against investigator choice of chemotherapy in the second-line setting. Patients had unresectable or metastatic esophageal squamous cell carcinoma who had progressed on a fluoropyrimidine-based and platinum-based chemotherapy. Median overall survival was significantly improved with nivolumab versus the chemotherapy regimen. Nivolumab did garner FDA approval for this indication, as well as support from the NCCN. The NCCN does have a number of preferred regimens for subsequent line therapy for upper GI cancers. Again, the more in-depth information is provided for you in the handout, specifically on the ramucirumab regimens, as well as trifluridine to Puracell for third-line treatment. Of note, a new FDA indication was granted to Trastuzumab deruxtecan just this past January 2021 for subsequent line treatment of HER2 positive cancers. This approval was a little too new to be included in the NCCN guidelines, but it is something to note. There are other regimens included in the NCCN guidelines if patients are otherwise intolerable or not eligible for the preferred regimens. With that, we will now move on to hepatocellular carcinoma, or HCC. Starting off with our patient case, JP was found to have a right liver lobe mass of 5.5 times 5.3 centimeters and an alpha-fetoprotein of 1,405 nanograms per milliliter. He was diagnosed with locally advanced unresectable HCC. Which of the following treatment options will offer JP the best overall survival? A. Liver transplantation. B. FOLFOX. C. Atezolizumab plus bevacizumab. Or D. Sorafenib. The correct answer here is C. Atezolizumab plus bevacizumab. This is based on the IMbrave150 trial, which compared atezolizumab plus bevacizumab versus sorafenib in the frontline setting. I'll go into this trial in a few slides when I discuss systemic therapy for metastatic disease. A is incorrect because JP has a tumor that is greater than 5 centimeters, making him ineligible for liver transplantation. B is incorrect because cytotoxic chemotherapy has not been shown to improve overall survival in patients with HCC. However, FOLFOX is an option for patients with unresectable or metastatic HCC if they cannot otherwise tolerate a TKI or anti-angiogenic agent. Answer D is incorrect, strictly based on the results of that IMbrave150 trial, showing that atezolizumab and bevacizumab provides an overall survival advantage over sorafenib. When we look at the treatment modalities for HCC, we're going to see our 3 common modalities we see for solid tumors of surgery, radiation, and systemic therapy. However, we're also going to see the addition of transplantation as well as other local regional therapies. The primary goal for localized disease is cure with surgery or liver transplantation. Otherwise, the goal does shift to palliative treatment. Often, the severity of underlying cirrhosis often limits treatment options since residual liver must be able to tolerate toxicity from treatment in order to regenerate. And so the patient's comorbidities are really going to drive which treatment modalities the patient is eligible for. In terms of local regional therapies, I would like to direct you to the handout, which has a very thorough table on the local regional therapies, what the types are, as well as their places in therapy. If a patient has resectable disease, surgery is the standard of care. However, the 5-year survival rates only range from about 30 to 40%, with a median overall survival of only about 3 years. Patients have to fall into very specific criteria in order to be considered for surgical resection, and this includes adequate liver function, usually Child-Pugh class A with no portal hypertension, a solitary mass of any size without major vascular involvement, adequate future liver remnant, and a suitable tumor location amenable to resection. If an extensive wedge resection is contraindicated, transplantation is actually an option, although the NCCN does recommend transplantation only if a liver is expected within 6 months. At this time, there's no recommendation for adjuvant therapy after surgical resection. Although sorafenib has been studied, it hasn't been shown to improve survival outcomes. Patients with unresectable disease are divided into 2 groups based on the reason for unresectability. If they are unresectable due to tumor location or inadequate hepatic reserve, they might be eligible for liver transplantation. Of course, those patients have to fall into a very, very specific criteria. They could be eligible for local regional therapy, which is preferred if the patient is not otherwise eligible for transplant. Or they would be eligible for systemic therapy, a clinical trial, or best supportive care. If the patient has unresectable disease either due to performance status or comorbidity with local disease or local disease with minimal extrahepatic disease only, the preferred treatment is local regional therapy. If the patient has either undergone that or is not eligible for local regional therapy, they would be eligible for either systemic therapy, clinical trial, or best supportive care. For patients with metastatic disease, they're really only eligible for systemic therapy or clinical trials, or perhaps even best supportive care if their comorbidities preclude giving them systemic therapy or they're not eligible for a clinical trial. The rest of the presentation on HCC will focus on our systemic therapies for metastatic disease. After many years of trying and failing to find systemic therapy for metastatic HCC, we finally got sorafenib based on the SHARP and Asia Pacific trials. These both compared sorafenib against placebo for first-line treatment of metastatic HCC. Both trials found significant improvement in overall survival and progression-free survival. However, the response rates to sorafenib were quite low. These trials established sorafenib as the first-line standard of care for HCC. After the SHARP and Asia Pacific trials were published, we had sorafenib for about a decade before anything else came along in the frontline setting. The REFLECT trial was a non-inferiority trial looking at lenvatinib in the frontline setting versus sorafenib. I do want to note and make sure you are aware that lenvatinib for frontline treatment of HCC is weight-based, either 12 milligrams a day for patients weighing 60 kilos or over, or 8 milligrams a day for patients weighing less than 60 kilos. The REFLECT trial was successful in showing the non-inferiority for overall survival of lenvatinib to sorafenib, and they also saw lenvatinib improve progression-free survival as well as overall response rates. Now, both of these drugs are multi-targeted tyrosine kinase inhibitors, and so we're going to see a lot of adverse events. The types of adverse events do slightly differ between the two agents. However, you have to really choose patients carefully to receive either of these due to the high rates of things like hand-foot syndrome, diarrhea, hypertension, fatigue, and proteinuria. Our last frontline treatment that I'll touch on in the presentation is atezolizumab plus bevacizumab. As I mentioned with the audience response question, this regimen is recommended based on the results of the IMbrave150 trial. This trial looked at treatment-naive, unresectable HCC patients and randomized them to either receive atezolizumab plus bevacizumab versus sorafenib in a 2-to-1 fashion. The median overall survival was actually not reached in the combination group versus 13.2 months in the sorafenib group, which was significant, and progression-free survival and response rates were also higher in the combination group. This led to the recommendation of using atezolizumab and bevacizumab in the frontline setting for metastatic or unresectable HCC patients. After our first-line treatments, we do want to know what are our subsequent line options. There are 2 TKIs that are recommended in the subsequent line setting for HCC. They are regorafenib and cabozantinib. The one big caveat to note with these is that because sorafenib was our only frontline option for so many years, both of these agents were only studied in the subsequent line setting after failure on sorafenib. And therefore, we don't have quite clear data yet on subsequent line options after lenvatinib or atezolizumab plus bevacizumab. I do want to also point out that the Celestial trial that looked at cabozantinib not only looked at this agent in the second-line setting, but also looked at it in the third-line setting as well. The next agent to discuss in our subsequent line treatment options is Ramucirumab. The REACH2 trial randomized patients who had progressed after sorafenib to either Ramucirumab or placebo. A very key inclusion criteria for this trial was patients had to have a serum AFP of 400 or greater. They found that Ramucirumab significantly improved overall survival and progression-free survival, but didn't significantly change overall response rates. The adverse events seen with Ramucirumab were typical of the drug. For the last few subsequent therapy options, I will discuss immunotherapy. So Nivolumab was studied in the Checkmate 040 trial, which was a kind of complicated phase 1-2 dose escalation, dose expansion trial that looked at both Nivolumab alone and Nivolumab plus Ipilimumab. The Nivolumab alone arm saw tumor response rates of about 20% and a duration of response of about 9 months, and this led to an accelerated approval of Nivolumab for the subsequent line treatment of advanced HCC. The other part of the trial looked at Nivolumab plus Ipilimumab in 3 different dosing schema, and the dose that had the highest response rates and median overall survival was the Nivo 1 mg per kg plus Ipi 3 mg per kg for the first 4 cycles, and therefore this is the dosing schema that's recommended for HCC. Based on the relative success of Nivolumab in the subsequent line setting for HCC, there was another Checkmate trial, 459, that looked at Nivolumab versus sorafenib in the frontline setting. However, this trial did not meet the pre-specified threshold for statistical significance for the median overall survival. The authors do conclude and support that Nivolumab still had clinically meaningful improvements in overall survival and response rates, even though it wasn't statistically significant. Pembrolizumab also has a bit of an interesting history in HCC. The phase 2 Keynote 224 trial showed that Pembro had an overall response rate of about 17% with a median progression-free survival of almost 5 months. So based on this, the confirmatory phase 3 240 trial was performed of Pembrolizumab versus best supportive care. However, Pembro failed to meet statistical significance for median overall survival. It's due to this confirmatory 240 trial as to why Pembro has a category 2B recommendation in the NCCN guidelines. So now, when we summarize all of that information for metastatic disease systemic therapy, we're going to see our first-line preferred options of sorafenib, lenvatinib, or atezolizumab plus bevacizumab. I would like you to note that a lot of these systemic therapy options are only indicated for Child-Pugh Class A. There are very few that are indicated for B7, and almost no agents indicated for Child-Pugh of more than that. The NCCN does support Nivolumab or Folfox in certain circumstances for patients who are ineligible for TKIs or other anti-angiogenic therapy. In terms of our subsequent line options for metastatic disease, the category 1 options are regorafenib, cabozantinib, or Ramucirumab. Again, Ramucirumab only indicated for those with an AFP of 400 or greater. And then we also have a slew of other options. So lenvatinib and sorafenib, if they weren't previously used, are options. Nivolumab with or without ipilimumab. And then Pembrolizumab, again, noting that it's a category 2B compared to the rest. And then, of course, we have our NTRK TKIs if the patient is NTRK gene fusion positive. And now, with the last few minutes of this presentation, I will cover radiation recall. We'll start off again with a case. HT is a 58-year-old female with locally advanced adenocarcinoma of the esophagus. She received preoperative chemoradiation with carboplatin and paclitaxel, which was followed by an esophagectomy. She's been observed for the past year for disease progression and unfortunately was found to have new liver mets. HT just received cycle 1 of fluorouracil and irinotecan, or FOLFIRI, and presents to the infusion center today for chemotherapy pump disconnection. She reports that the skin on her chest is red and painful to touch. The physician is concerned HT may be experiencing mild radiation recall. So which of the following management strategies is most appropriate for HT's mild radiation recall? A, observation and continue therapy with no modifications. B, supportive care and continue therapy with dose reduction. C, steroid premedication and continue therapy with dose reduction. Or D, high-dose steroids and discontinue therapy. The correct answer here is answer A, observation and continue therapy with no modifications. Answer B isn't completely correct. Although supportive care can be used, which includes moisturizers, NSAIDs, oral and topical antihistamines, we wouldn't dose reduce for a mild radiation recall. Answer C is also not entirely correct. Although steroid premedication could be considered, again, we wouldn't dose reduce for a mild radiation recall. Answer D is incorrect because high-dose steroids and discontinuation of therapy are both indicated only for severe skin reactions. So what exactly is radiation recall? It's an inflammatory reaction that occurs in a previously irradiated area that is precipitated by administration of a chemotherapy agent. The incidence is incredibly difficult to determine as this is mostly reported in case reports, although we can guess it's about 6 to 8%. It's also unclear if it's a drug class effect or related to the drug dose and or regimen. I have listed for you here, as well as in the handout, chemotherapy agents that are known to be associated with radiation recall. So although radiation recall most commonly affects the skin, it can also affect internal organs and cause mucositis, colitis, myositis, pneumonitis. The onset typically occurs at least 7 days after the completion of radiation therapy, which can sometimes be confused with radiosensitization. However, it has been known to occur weeks to even years after the radiation exposure. Similarly, the symptoms can occur days to a few weeks after exposure of the offending chemotherapy agent. However, it has been known to occur immediately during or after intravenous infusion or after multiple cycles of exposure. With oral agents, it may take weeks to months to occur. So I just want to point this out that the timing of radiation recall is incredibly varied and should always be in the back of your mind if a patient presents with a rash in the area that they were previously irradiated. So if a patient does present with radiation recall, there are some management strategies based on whether it's a skin reaction or a reaction internally, and based on if it's a mild to moderate reaction or severe. In general, for skin reactions that are mild to moderate, close observation is fine with or without supportive care interventions. When we get to severe skin reactions or any reactions involving internal organs, we're typically considering discontinuing or at least dose reducing the offending agent and initiating various supportive care techniques. Of note, re-challenge does not always elicit a subsequent reaction, and therefore really depending on the reaction the patient had will determine if you should re-challenge. With that concludes this presentation, and I'd like to thank you for your participation.